All right, so let's talk about the outline. So we're going to be discussing why we document, some of the medical decision making that should go into our documentation, some of the medical legal, and most importantly, efficiency tips. So if there's anything you take from my lecture, is if it wasn't documented, it didn't happen. All right, so why do we document? Well, we document primarily for 6 reasons: billing, reimbursement, medical legal, communication with other healthcare providers, research, quality improvement, risk management, and utilization. So, but today I'm primarily going to be focused on the medical legal, the efficiency, and the billing and documentation. So what is documentation? It's this thing we've been doing since we were medical students. It's a chart, it's a document, it's something that represents what happened in the emergency department. And it stems from parts of HPI, you guys remember, OPQR, review of symptoms, including pertinent negatives and pertinent positives. Moving on to our physical exam, and most importantly, our medical decision making, our MDM. So prior to 2023, when we were getting billed for our documentation, it was primarily initially HPI, review of symptoms, physical exam. But as of 2023 moving onwards, through the, instead of the Centers of Medicaid and Medicare, it's now implemented by the American Medical Association with CPT, and now majority of our documentation is going to be heavyweight on our MDM. And personally, I think that's a bit better. It's now doctors that are the ones in priority of the things that we get reimbursed for. So how do we actually get billed for our MDM? Well, our MDM is about 5 levels, ranging from high complexity all the way to straightforward. There's actually a level that's not depicted here, which is a chart or an evaluation and management that doesn't even require an evaluation of a qualified healthcare professional. In terms of what we care, we're going to be trying to get into this high complexity, this level 5 MDM. But what does that actually mean? Well, there's 3 specific elements of an MDM that go into an MDM. Breakdown. Cool. 3 elements. All right. Ranging from the complexity and the number of problems, the amount of data and the complexity of that data that needs to be analyzed, and the risk of the complications with the management and diagnostic testing. So let's first off break down the problem. So when we're talking about problems, I want you guys to look at this bottom area right here, where it's I. Fine.
Just use the test.
Hold on. All right, cool. Hi. So what I'm trying to illustrate here is a chronic illness with severe exacerbation, or an acute or chronic illness with threat to loss of limb or loss of life are going to get you to that high MDM status in terms of problem. Note that not every single chief complaint, like a finger laceration, is going to be able to be billable at that level high status. Not everything's going to be able to be billed at that level of high status. No, this is not the actual final diagnosis, but it is what is concerned with that. So say for something like a subarachnoid hemorrhage, or someone comes in with a headache, and you're diagnose them with a... No.
Trying to help.
No worries. Maybe this will go. Okay, whatever. So say someone comes in with a chief complaint of headache. It's not the risk of the headache. It's the risk of you needing to tease out things like a subarachnoid hemorrhage, meningitis, encephalitis. So that's what's actually going to get you to that level of high complexity in terms of problems. Next, let's get into terms of data. So to get to that level 5, that high complexity MDM, your documentation needs to show 2 of these 3 categories. And let's first start with category 1. So I want the audience to raise their hand if they ever reviewed a prior chart before. Cool. Raise your hand if you ever reviewed a test that you ordered. Raise your hand if you ever ordered the test. All I'm trying to document and illustrate is that these are things that we're doing all the time. We just need to put this into the documentation. We need to put this into words that coders can see to properly get billed and reimbursed for it. Next, in terms of category 2, it's independent interpretation of tests. documenting your own POCUS, documenting your own ECG read, your own chest x-ray read. These are things that we're doing all the time. We just need to find a way to be able to implement these into our documentation so that the coders can recognize these terms and accurately reimburse us for this. And last, category 3, discussion and management of test interpretations. You discussing your results with radiology, you discussing your results with CT, things we're always doing. We just need to get this into the chart. So this is just an example of those categories. Say someone comes in, you say like the white blood cell count shows all of this. That's category 1. Chest x-ray interpreted by me. Category 2, discuss management. Category 3. These bolded words are things that the coders are going to recognize. And we're going to get more into how we do this efficiently when we get to the bottom part of my lecture, the efficiency aspect. So next is risk. And this again is not the risk of the specific complication. Is the risk of the complication from the management and diagnostic testing. For example, you see where I'm shortening. The risk of radiation from an x-ray, the risk of radiation from a CT, the risk that you might do from a specific procedure, thoracentesis, lumbar puncture, the risk of even ordering like antibiotics, the side effects of those, the risk of IV drug use, benzodiazepines, all things that we're doing already, things again that we just need to somehow get into our chart. So I know this is a wordy slide, but this essentially is a summary slide of everything we've covered in MDM thus far. So starting with problems, the complexity and the numbers addressed, to get to that high level, again, it's not the final diagnosis of what we're working of, it is what the things that we need to rule out. Someone comes in with chest pain, even though you diagnose them with the diagnosis of GERD, you still had to rule out ACS, you still had to rule out PE. And that's how we get to that acute/chronic illness with a threat to loss of limb or life, or chronic illness with severe exacerbation. Next, we talked about data. Healthy.
But get rid of the emotional support.
Okay. Do we have to click it?
Click.
Okay.
Okay, there you go.
Cool.
Click.
Thank you. Okay, next in terms of data, again, we need to satisfy 2 of these 3 categories to satisfy this high complexity level 5 MDM, the things that we reviewed thus far. And in terms of risk, again, it's the risk of the complications of the specific diagnostic testing or intervention that you might do. All right, that was a lot of words. Now, how do we actually implement that into the chart? Well, it comes from 9 key MDM drivers, things that we do all the time that we just need to get into words that coders can recognize. Number 1, discussion and management with other providers. Did you consult PIC? Did you speak to social work? Any consultants, you should find a way to document that and put that into the chart. Independent interpretations, chest x-ray, POCUS, EKG, review of external records. You just looking at a prior chart before. History obtained from independent historian. Did you talk to the patient? That's an independent historian. As well as home health aides, family, nursing records, anyone that you spoke to, EMS personnel as well, prescription medications, anything that you ordered, chest x-ray, labs, ultrasound, care affected by social determinants, really news to me. So you even documenting that their care was affected possibly by their uninsured status, appropriate consideration. So you documenting that you consider possible observation with chest pain or maybe admission. Chronic illness is impacting care. Almost every single one of our patients has some type of chronic illness impacting their care. And lastly, discussion and tests with other external providers, radiology. So that was a lot, and we're going to get back to that more in efficiency aspect. Let's talk a little bit about critical care documentation. So critical care documentation can be implemented when you spend at least 30 minutes with a patient and that patient's medical condition led to either threat to loss of limb, loss of life, or there's a concern for imminent decompensation. So on the slides are some of the common things that we see that can apply to critical care billing. I want to highlight that a lot of the procedures and diagnostic testing we do also go into critical care billing. And I also mostly importantly wanted to highlight on this left side, the things that should be billed separately and would not go into our actual critical care documentation. There's essentially 3 levels of critical care documentation, that 30 minutes to 74 minutes. After that is any additional 30 minutes after that initial 74 mark. And then there's also critical care billing for any trauma code activations. So It's very important to make sure that your documentation shows why this patient needed to actually apply for critical care billing. And the ways you're going to do that is by documenting how that patient was sick, their vitals, any information you collected from EMS. You're going to document the things that you did, the interventions, the workups, the treatments, and most importantly, you need to document the time. So this is an example of how someone might just have a dot phrase of their critical care billing. Cool. So let's talk about medical legal. Let's talk about not getting sued. It's estimated that about 75% of physicians are going to encounter a lawsuit during that time. And about 20% of these issues are due to documentation issues. That is not to say that poor documentation leads to a lawsuit, but it could give extra ammo for a plaintiff to show that you provided medical negligence, you did things that you should have, or maybe you just did not actually care about the patient. That is not to say that that's why we get sued. To be honest, majority of the time physicians get sued is because of bad outcomes and unhappy patients. So when I say it wasn't documented, you say, let's go. So I'd be very careful about documenting a differential diagnosis. It's okay to list them out, but I would be very cognizant about how you're doing that. For example, say someone comes in with this chief complaint, you list your pertinent negatives, your pertinent positives, and a review of symptoms. Your MDM looks something like this, likely this, doubt all of these. A plaintiff might see this and say, yeah, you listed them, but you did absolutely nothing to address them, so we're still gonna hold you accountable. Instead, I challenge you when you're doing your MDM to put reasons why you're not working things up or why you're not getting the actual diagnostic testing. For example, doubt subarachnoid hemorrhage, no thunderclap onset, no neck pain, no neck rigidity, doubt meningitis encephalitis, no infectious symptoms, no neck pain, no rigidity, instead of just listing them out. When it comes to discharge, it's really important that your documentation shows that you addressed any triage complaints, that you addressed any vital sign abnormalities, that you address all the diagnostic testing, that you make sure that you're readdressing the patient's symptoms. And if any of these things are abnormal, make sure your documentation shows the justification for discharge. So other medical legal tips, be wary of dirty words in the chart, things like rude, malingering, ugly, I don't know. A plaintiff might use these things to say that, wow, you are actually not liking the patient. You did not like the patient. They might use this as extra ammo against you. It's really great, and defending attorneys really love when we document our shared decision-making with the patient, as well as when we're documenting any risk or benefits of why we considered a procedure or we didn't, and also the documentation of what the conversation we had with that patient. Make sure your documentation supports your final diagnosis. If it's something like GERD, make sure your documentation represents that. And make sure for common complaints like headache, chest pain, you're documenting a thorough physical exam. Lastly, I make it a point to overly document when I'm doing less for a patient. A young woman comes in with headache that I'm not getting a CT head on. I'm making sure I'm documenting a great thorough exam. I'm making sure I'm documenting everything. Whereas if someone comes in for aortic dissection, I'm saying getting labs, getting CTs. And you'll see it in the chart that I am working up these more emergent pathologies. So let's get to the meat and the potatoes of the lecture. Efficiency. How do we get faster? How do I get y'all to stop staying 2 hours after in the pod writing notes? Well, let's get into some tips. First off is dragging dictation. I don't know about y'all, but I cheated during my typing lessons, and now I type like this, so I am so slow. I am so slow at typing. So this is probably one of the most important factors of how I'm so speedy about my documentation is just dragging dictation. Interns, I urge you the first few months of residency, try and just stick to typing. As you get a bit more seasoned, you'll be able to your thought processes will be a bit more streamlined. So dictation will be a bit more easier for you at that time. Whereas I think it'd be a bit more of a challenge if you try to start it off right now. Next is review of symptoms or acronym expansion at downstate.
None of you.
I do. I'm telling you, I'm not staying after even side of the street. So this is really important too. I use this for almost all parts of my chart. My review of symptoms, I use it for my discharge, I use it for my AMA. This is really important. One thing I'd like to urge you guys is to make sure you are double checking before you sign that note. It's so easy to have a review of symptoms and just to leave it as is. Whereas when you look back and you see, oh wow, denied headache, That was your chief complaint. So plaintiffs can use this to say that there's medical inconsistencies in the chart, which if in the case where someone raised a complaint or file against you, that could give extra ammo for the plaintiff again. One way I like to get around that is using asterisks, 3 asterisks in my review of symptoms. So I have to make sure it's something I check off if I actually signed the chart. Next is order panels. I think this is really helpful, especially in the CCT. I have it for trauma. We have our own for stroke, which for some reason doesn't include a hepatic function panel. So just be mindful of the pre-stroke notification. And the cool things about these, yeah, we should just fix it. The cool thing about these is that they're dynamic, they're flexible. Just because you have an order panel doesn't mean that it's just set as is. So for my trauma order panel, trauma labs and trauma imaging, and I can just quickly click all of those. So when the trauma comes in, it gets done quickly. I urge you to not repeat what was already in the chart. So say when I'm getting to my MDM, comes in with this, vital signs stable, exam as documented in the chart, something see above. Like it does not make too much sense for me to write out something again if you can just go in the chart and see it again. So let's get into some efficiency tips. So when it comes to my HPI, what I usually do for my fast typers, you can just type this out, but I dictate a one-liner. I say my pertinent negatives. I say my pertinent positives. I have my dot review symptoms headache. And then I make sure I delete anything that's not true. And I have an asterisk by OCP use because like, oh snap, your patient was a gentleman. Why is that even in the review of symptoms? And then, what was I going to say? And then sometimes it keeps me accountable too. Like I forgot to ask the patient coming in with like temporal headache if they're having changes in their vision. Next, when it comes to physical exam macros, I honestly have 99 problems, but pushing buttons ain't one. So with my physical exam macros, again, I urge you to make sure that you're double checking what the macro is. When I was earlier in my course, I would sometimes have like normal rate, normal rhythm, belly soft, non-tender. My brother, the patient came in with tachycardia of 130, like another inconsistency that's in the chart. So my physical exam macro is honestly very minimal. It's almost an exam that I can do just by looking at someone. No acute distress, non-toxic, no respiratory distress, no focal neurologic deficits, conjunctiva within normal limits. Moving on. Okay. So now the meat and potatoes, the MDM. We just talked about how much of our billing and document and reimbursement comes from our medical decision making. How do we actually implement that into a chart in a timely manner? Well, it starts with a dot phrase. So I have my own dot phrase. You can copy it, and if you want to, all my own dot phrases start with "Ola." So I'll dictate my own quick MDM, and then I'll just do this dot phrase just to have the things that I miss. So for example, all the things that we talked about before, those 9 key MDM drivers. So for example, from the headache from before, I'll copy paste my one-liner, exam as documented. I'm not repeating what was already put in the chart. I do my own differential diagnosis, and then I just dot my MDM and do the things that I normally wouldn't. So independent interpretations by me, the EKG, review external records. I looked at the chart before, history obtained. So that's how I'm getting to these 5 level 5 high complexity MDMs whilst doing this in under 90 seconds. I timed myself. So let's get to some of the discharge. So when it comes to discharge, make a dot phrase. My dot phrase includes like dot Ola discharge. At this time, patient's hemodynamically stable, asterisk, 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 tolerating PO, asterisk, 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 ambulatory without ambulating at baseline. At this time, patient is understands the care plan, has appropriate follow-up, and understands the return precautions. These are things that we're always doing. Now it just takes about 3 seconds just to get into the documentation. And lastly, just do it. Like I'm talking to my juniors and my interns. I'm like, why are you guys having to stay so long? And so much of it is this ED, ADHD. There's always another task. You're moving up. You just don't want to document it. Just document it. We talked about how important the medical legal aspect of this is having a solid chart. And what gets to a more accurate charting is recency. So if you're waiting to go home or you're waiting weeks to do these charts and you're just putting whatever, God forbid that some type of complaint gets raised against you. And now because you didn't just document in a timely manner, you have all these inconsistencies in your chart, it can make you a bit more at risk. I urge everyone to try not to be more than 4 notes at a time. Of course, when you're in the CCT, you got to go stabilize the patient. But when you're in the pod and everyone's safe, like take that second to catch up on your notes. So let's get to our takeaways. If it wasn't documented then, it didn't happen. We discussed a bit about how to document an MDM, and we talked about some of the efficiency tips. Dictation, dot phrase / acronym expansion, order panels, exam macros, and just do it. These are my resources. All right. Anyone have any questions or comments?